So, hello everyone, welcome back to the White Coat Wisdom. I am your host Akshar Chugg, and in today's episode, we'll discuss about clinical postings. Clinical postings are the heartbeat of medical education. It's a transformative phase where the textbook knowledge meets real life patients and you learn clinical application. It also helps to turn the theoretical knowledge which you have been studying in the books into hands-on experience. So in this episode, we will dive into why clinical postings are a cornerstone of medical training, the invaluable skills they offer you, and how it shapes you as a good doctor in future, and how you can make the most out of them to lay a strong foundation for your medical career, as well as balance it with the regular studies of your medical school. So without any further ado, let's get into it. Now from this podcast onwards, I will like to give you all a sort of overview of what all topics we will cover in the podcast, so you guys exactly know that what all aspects will be covered in this particular episode. So first of all, I will talk about clinical posting, the academic and the non-academic benefits that clinical posting offers. Second, I would like to mention a eminent personality, Dr. William Osler, who was very pivotal in advocating bedside medical study rather than studies in the lecture hall and in the classrooms. And finally, I would like to share some do's and don'ts of attending clinical postings to the juniors. I have survived 3 years of clinical postings, and I have a lot of things which I wish someone told me earlier when I was in my second year just starting my clinical postings. So I would love to share them with all of you. So let's begin. So starting with the academic benefits of clinical posting. First of all, you get to see all the pathology and all the clinical findings on the patient itself. Like I've talked in my earlier episodes, most of the practicals we do in physiology in first year are on normal people or usually on the colleagues and the batchmates. Most of the time, you would only find normal findings in them. The first encounter of abnormal clinical findings would be in the second year when you enter the clinical ward. So all the knowledge that you have gathered in your first year as well as in your second year of pathology will be put into work. You would start appreciating things, you would start appreciating clinical signs, you would start appreciating clinical complaints of the patient. Second thing is problem solving. In the second year, the first thing you are taught is basic history taking. So in second year, it would seem a bit daunting about why are we asking all these questions to the patient where when the patient just complains about abdominal pain. But as and when you progress through the medical career, you start to understand all the points that we ask in any complaint are primarily to rule out the differential diagnosis of that particular complaint. And secondly, it is to localize the lesion, to localize the pathology. So as and when you take more histories, as and when you take more cases, we'll start developing a picture in your mind, a sort of mental model in which if a patient of abdominal pain comes to the OPD, you know what all things to rule out, what all signs to see during clinical examination, and what all investigations are to be done in a patient of suspected abdominal lesion. Third thing is interdisciplinary learning. So the beauty of medical sciences is, so we have 19 subjects in total that we study across 4 years, right? The beauty is, whenever you enter the ward, the patient will not present as a patient of medicine, the patient of pediatrics, as a patient of ophthalmology. The patient will present as a functioning unit of all of the 19 subjects of all of the clinical and medical sciences together. And that's the beauty of clinical medicine, that you see a patient as a whole and you do not see the patient as just gastrointestinal system or just respiratory system. So it's the first time that you appreciate the beauty of integrating different subjects and different systems together in a patient. For example, the way a second year medical student would look at a hepatic failure patient secondary to alcoholism would be completely different that the final year medical student would look at the same patient. The reason being, the second year has the perspective of the first year knowledge, in which you would see the anatomy of the liver, the physiological functions of the liver and how they are deranged. You would also see the biochemical changes that occur into blood because of liver failure, and probably a bit of pathology about liver cirrhosis and liver failure. Whereas a final year medical student would have additional perspectives from surgical field, from clinical medicine. He could also read the radiological reports which are present in the file. So this is how the perspective of the students change as and when they progress through the medical years. Finally, early clinical exposure. Now it's imperative to get early clinical exposure in this day and age. The simple reason being, in the age of AI, where it can predict and nearly have the diagnosis just by itself, it's important to pick up small clinical signs, small clinical clues that the patient sometimes won't tell you unless and until you specifically ask about that complaint. Second part is about the non-academic benefits of clinical posting. The first is you would learn empathy and compassion towards the patient. You would be literally standing in front of a patient who is in dire need of a liver transplant, and you could do nothing, and you know that if the liver transplant does not take place, the patient would be no more after a week. So this very gravity of situation makes you a more empathetic and a more compassionate human. Especially these qualities are so imperative to be a good doctor. You would also develop listening skills. As a doctor, what I feel is it's becoming more rare to find such a doctor who listens to the patient very well, who does some active listening rather than passive listening. In the end, what people want is to be able to trust you, to trust that you have the skill and that you have their best interest at heart. They want to know that you are reliable and that you care about them, and you will advocate for them. That hasn't changed throughout centuries. It won't change whether we learn how to prevent a lot of disease by genetic intervention. In the end, when people come to you for care, that's what they're looking for. That you know your stuff and you care about them. The fusion of science and humanity is what it's all about. And if you excel at both of them, you would become a really good doctor. So this skill is what you get to practice, is what you get to sharpen right from your second year onwards. Third is career exploration. Now, I vividly remember like when we were going to the postings in our second year, many of our seniors told us that in second year you really don't know much about medicine and patient management. Then what's the point of going to the posting? And I completely agree with them. We literally would stand in front of the patient, looking at the patient, trying to figure out what's wrong with him or her, and asking random questions about where they live, what occupation they do, and what is their chief complaint, and why are they admitted. So we were completely clueless at that point of time. But the good thing is we got to rotate through all of the clinical subjects in that year and in the year forwards. And what it helps is you start to develop inclination towards a couple of branches throughout your clinical posting. If you don't know what you want to do, you would definitely come to know what you don't want to do for the rest of your life. And at least you would know that are you a surgical person or a medicine guy. That's what's very important, because many of the people who literally skip and bunk the clinical postings, at the end of the day, when they have their results, when they have achieved a good rank, they don't know what's there in the field they are choosing. Most of them choose the top branches, radiology, dermatology, and many of them regret taking the decision because radiology and dermatology are the most overlooked subjects in terms of posting. Like, people still attend medicine posting, surgery posting, OBGY posting, but dermat and radio postings are just swept under the carpet, and no one really takes the effort to go to the radiology and dermatology postings. And the final non-academic benefit is you would make great relations with the residents, with the interns, with the seniors, with the juniors who are accompanying you in that particular medical ward, to the SRs, to the consultants, and these relations and these friendships, they come handy in a lot of places. For example, I had very good terms with all of the residents and the interns and the SRs and even consultants across majority of the subjects. And whenever I felt lost, whenever I felt like I need to get some career guidance, I always approached the consultants of that department, and they were very kind and happy to help me out to resolve the conflict. And the residents and the SRs, they teach you a lot if they see that you are curious to learn. The first year PGs are definitely very busy in their ward work and clinical work, but the second and third year PGs, they teach you a lot of stuff. I was glad to perform and learn many interventions such as lumbar puncture and intubation, which are usually done by the residents, not even the interns, just because I was curious and I used to stay back a lot after the clinical posting hours got over, and I was always ready to learn, ready to help them in their work. So they are quite helpful if you know how to build relations and if you appreciate the value of these clinical skills. In the next segment, I would like to talk about William Osler. So he's considered as the father of modern medicine, and there is a quote that he wrote in his book that he who studies medicine without books sails an uncharted sea, but he who studies medicine without patient never goes to the sea. So the thing is that going into clinical postings without theory reading is just as useless as not going to the clinical posting at all, because if you have a solid theoretical base of your study, only then it is that you could help the patient, you could relieve the patient of their pain. And without clinical knowledge, just going to the ward, standing there, seeing the ward rounds, it would not be that useful. But if you have done your active studies, if you know the topic in and out, and then you see a workup of a patient, you really know why this test was sent to the lab, why this patient is started on this drug and not the other one. Like, William Osler was a very big proponent of bedside learning, and he was the one who introduced bedside learning in medical colleges and medical school. Before him, the medical school was completely based on chalk and talk method. There were only lectures and classroom discussions about medical case, and the medical student was not allowed to go anywhere near to the patient. And if any one of you is inclined towards internal medicine or clinical medicine, you should watch his documentary on YouTube, and you should read him at least once in your life. So in the third segment, we will talk about the do's and the don'ts of clinical posting. So starting with the do's, I wish someone had told me these things when I was starting out with my clinical posting in my second year, but I'm happy to share the learnings to the juniors, and here we go. So the first to do is you need to do case-based studies and case-based application. Now, what do I mean with that? Whenever you go to the ward and whenever the lecture of the clinical posting is over, you are free. You are free to look at the patient, you are free to take history, even do some basic clinical examination. So what I did most of the second year and even third year is strolling through the ward, seeing if I see any unique case, if I see any new and novel case that has come to the ward. But rather than doing that, I would like to first study and to first see all the patients which are more common. For example, in GIT, alcoholic liver cirrhosis is one of the most common patients that you would find in any male ward in any hospital throughout the country. You could also find acute gastroenteritis, upper GI bleeding, lower GI bleeding. So I want you to ask your consultant or your SR about the important long and short case that are asked in your exams, and usually they are the most common cases encountered in the ward. So first of all, in the start of your posting, I want you to master them, and then after, if time permits, then you can wander around and let your curiosity be free and see patients of other systems, to see patients with any novel diagnosis. If you are into research and case reports, you could also find rare cases in your wards. I did case reports on 2 such cases, which were quite rare, and I would also like to mention that you should at least keep a journal or a diary. I regret that I didn't make a diary in my second year, but I urge you to keep a journal, keep a diary in which you note all the interesting cases you saw, all the interesting patient encounters that you had, and the different experiences you had in the hospital wards. So they would serve as a very sweet memory when you graduate and when you become a doctor. So that is one thing you should do. Third is active observation. Now, whenever any procedure is done or whenever any examination is done, if you have read about that examination, for example, the consultant is performing a hepatojugular reflex, then if you know the theory behind it, if you know the causes, if you know the DDs, then you will actually learn more out of it rather than just standing there and looking for the hepatojugular reflex for the first time. So active learning is very important. It can literally give you thrice or quadruple benefits rather than just passively studying and passively attending the wards. Fourth is always keep a practical guidebook handy. It could be any practical guide, Indian author, foreign author, but it should be with you either online or offline to look up to any procedure or any differentials that you are confused between. Now, moving on to the don'ts of clinical posting. So first of all, I don't want you guys to be demotivated or feeling nervous about going to the wards. In second year, you are literally the last rung of the food chain. You would be looked down upon, you would be mocked or ridiculed even. I still want every one of you to at least go to the wards 15 days out of 30 to get that feel, to develop that taste, because the reason why we worked so hard in the NEET UG days was to get a government seat. And why did we want government seat? Because there is a good amount of patient inflow. So it really makes you a good doctor if you go to the ward, if you go to the clinic, because that's what you are going to do for the rest of your life. You are not going to sit in a library and study books and study coaching material for the rest of your life, right? So it's equally important to study and get your theoretical knowledge right. It's equally important to crack the post-graduation examination. I do agree with that, but it's equally important, or rather more important, to go to the wards, to go to the clinics and develop a feel of history taking and developing a feel of a doctor. You should be flawless with your clinical examination. You should be flawless with your communication with the patient. You should not make the patient uncomfortable in your presence. Even that's a skill that it's important to learn. Do not make the patient feel uncomfortable while you are taking the history, while you are clinically examining the patient. Second don't is don't get overwhelmed. So in initial years of clinical posting, like in second year, in third year, you would feel there's a lot to learn. There are a lot of things that I don't know about the ward. I'm completely clueless, but that's normal. Just need to ask a senior, a good resident, a good SR that why are we doing this procedure? Why are we giving the drugs? But it's equally important to not be a hindrance in the wards. Like if a resident is performing a procedure, or if they are busy in taking the notes of the rounds, better not disturb him. Catch hold of a resident who is relatively free. Like no resident would be free, but you need to identify the one who is relatively free and ask him the questions about the ward. Also keep in mind that the person you're asking is in a good mood right now. So that's all about the do's and the don'ts. And with that, we wrap up the episode about clinical postings. I hope you learned a couple of things from the episode, and I hope to see you guys in the board. So till then, keep learning, keep enjoying, and be curious.